Welcome, everybody. We'll start in just a minute. Okay, we're at the top of the hour. Why don't we go ahead and get started? Welcome, everybody, to our last Long COVID and Fatiguing Illnesses Recovery Project webinar of the year. And it happens to be our 12th one. We started with our soft launch about a year ago. So very happy to have you here. And we're delighted at the session for today, making a little bit of a shift from our last month, which was disability focused, towards occupational medicine and post-COVID conditions. If I could have the introductory slides up, we'll go through some housekeeping items first, and then I'll pass it to John to introduce our speaker. And I should have said, by the way, I'm Christian Ramers, infectious disease doctor here in San Diego and one of the PIs of the program. So let's go with the intro slides to go through housekeeping items. Now, many of you are old pros at this, but we like to go over all these things very quickly at the start of each session. And full screen. And next slide, please. Great, so just very quickly, our logistics. We like to use the Zoom Q&A function, which is going to be on the bottom of your screen to the left. If you have a specific question that you'd like us to address in the second half of the hour, please form it in the form of a question and make comments there. The chat we're going to reserve mainly for posting links and information for you to click on later. The session is being recorded and your attendance is consent to being recorded. Thank you for that. The presentations, I know you're going to ask, they will be linked in an email announcement, all the slides and all the materials later. And also we record all these sessions and the sessions are all available on the Long COVID and Fatiguing Illnesses Recovery Project ECHO website. In terms of CME, oops, sorry, go back one, please. In terms of CME and related links, towards the end, there will be a link to obtain your CME credit as well as a post-session survey towards the end of the session. Look out for that. We like to keep these sessions apolitical and non-commercial. Thank you for that. And please keep in mind our main charge and our main audience here is directed towards primary care clinicians, caring for patients with long COVID and other fatiguing illnesses and focused on patient management. We realize that it is an open invitation for anybody to attend, particularly those who are suffering from long COVID symptoms, but really our focus and our dialogue is going to be directed at primary care management. Next slide, please. Project ECHO does collect registration, participation, and some more information and shares this data with family health centers and the CDC, and your individual data will be kept confidential and de-identified. Thank you for the permission to use that data. Next slide. And the next slide, please. Oops. Can we have our deck back up, please? 1 minute. Okay, you know what? I think what we'll do is actually go through those slides one more time at the end because I'm hearing that they froze and we'd like to move on with the presentation. So let me pass it over to John to introduce our wonderful speaker for today.
Okay, thanks, Christian. My name is John Scott. I'm, like Christian, an infectious disease doctor. I'll be co-facilitating the discussion today, and I'm at the University of Washington. So it's my pleasure to introduce Dr. Sarah Diekman. And I think she probably has the most initials after her name of anyone I've seen on this panel. So relevant to the discussion today, both a physician and an attorney. And she's going to be talking about occupational medicine and post-COVID conditions. So she is director of the Diekman Dysautonomia LLC and an adjunct professor and instructor at the University of North Carolina, Gillian School of Public Health. She earned her MPH with a concentration in epidemiology and research from Johns Hopkins. And she did her residency at Johns Hopkins and also got her JD from Florida A&M College of Law. So I'm going to turn over to Sarah, and thank you for presenting today.
Hi, thank you for this opportunity to present today. Let me get my slides up. And all right, does that look good?
Looks great.
All right. So I'm going to be presenting on occupational medicine and post-COVID conditions. A little bit about my background. I think you've heard most of it, but certainly the JD informs my approach to patient care because I really understand the power that physicians have when it comes to the ADA protections. My experience in the physician community is that they underestimate the power that they have. Just a few words on a page can really give your patients a lot of rights to protect their health in the workplace. So I think you have more power in your hands than you may realize. A brief outline of what we're going to be covering. So my specialty, I'm trained in preventative medicine, occupational medicine, and what I've really have done with that is use that on a specific patient population, which is dysautonomia. And that includes POTS that has presented from long COVID and then other types of long COVID. Throughout the presentation today, I'm going to use POTS as the prototype for workplace accommodations. And before I get into the actual really using it as an example, I'm going to just go into a little bit about my approach to POTS so you can see how my clinical approach begins and then how I carry that over to help my patients work and function in school and work. So a little bit of perhaps it's a review, perhaps it's news about POTS and the post-COVID syndromes. So this is a direct quote from a news source, and I thought this brings the bridge together pretty well. That while COVID is new, post-viral illnesses are not. Long COVID patients are now finding themselves as part of a larger community of chronic illness patients, many who have been seeking answers for years. Long COVID has increased the number of POTS cases that we have seen. So I think it really remains to be seen or categorized whether the post-viral POTS that we're seeing, is this different or is this an extension of other types of post-viral POTS that we've seen? I categorize it as a long COVID and POTS presentation. So some of the most classic symptoms that will present are the ones, the big four that you see here, and then with the addition of orthostatic intolerance. So the lightheadedness, often from orthostatic intolerance, nausea, fatigue, and pain. I think worth noting here is that fatigue is often a predominant symptom. It can be mistaken for depression. And also the nausea and other GI symptoms, I think, are often completely forgotten as symptoms of dysautonomia. I've seen many, many patients that have been told that the tachycardia is the only part of this symptom or syndrome that is tied in, that their GI symptoms are separate. So I want to emphasize that GI is very much a part of dysautonomia and specifically the POTS. So we're going to go a little bit into the nomenclature here. So many long COVID patients are presenting with dysautonomia symptoms. And dysautonomia is a non-specific term for abnormal functionings of the autonomic nervous system. And then when we talk about POTS, POTS is under this umbrella of dysautonomia. So there's many things that fall under this umbrella: orthostatic intolerance, neurocardiogenic syncope. And sometimes a patient does not fit diagnostic criteria for any of these, but they clearly have the cluster of dysautonomia symptoms. I'll end up using dysautonomia, NOS, or unspecified diagnosis. So linking, where does this fit in the long COVID, and why are we suspecting that these things are related? First off, we've seen a dramatic increase in the number of case reports of dysautonomia amongst long haulers. Many of the symptoms are characteristic for POTS. And we've long known that POTS has a post-viral nature to it. Anywhere from 40 to 50% of cases had a viral infection beforehand. And many clinicians are not familiar with POTS, which it can be a very subtle clinical finding on the surface. Patients can often have a very normal physical exam unless maybe you do orthostatics on them. So it's very important that we continue to talk about this diagnosis. So what does the name actually mean? So the POTS, P-O-T-S, stands for postural orthostatic tachycardic syndrome. The postural comes from the positional nature. The orthostatic is related to the standing upright. The tachycardia is the increased heart rate, and the syndrome is the group of symptoms. I think the syndrome aspect of it is the easiest to forget about. It's the most common to forget about. The diagnostic criteria is mostly based on the tachycardia, which can give a very limited view to a syndrome that affects multiple organ systems. So a review of the organ systems that it affects, which is the most fundamental organ system of our body, the autonomic nervous system. So essentially the system that we're not consciously in control of, and that is running most of the organs of our body. And so we have the parasympathetic system, which is the classic rest and digest system, and the sympathetic system. So it's still a research question wherein exactly the problem lies. And it may be multifactorial, and we eventually, hopefully, will be able to give more precise diagnosis of exactly what is dysfunctioning and where, and there probably are multiple locations, multiple presentations. But what is pretty accepted is that there is an imbalance here between where normally the parasympathetic and sympathetic systems are balancing each other, whether it's compensatory or primary. There becomes a sympathetic overdrive and a lack of parasympathetic activity. And that results, again, in the multiple organ systems, the increased heart rate, changes in pupils, dry eyes, dry mouth, digestive problems, all the fight or flight, like puts the body into a fight or flight stance. So now the diagnostic criteria is, so the classic way that this is diagnosed is with a tilt table test, and I'll have a picture of that in a moment. And we're looking for a 10-minute stand on the tilt table test at 70 degrees, and looking for a heart rate increase in an adult of at least 30 beats per minute in the absence of orthostatic hypotension. Now, this criteria is a bit controversial. Some clinicians will stick to it precisely, but where others, I have seen patients that don't get the 30 beats per minute change until minute 11. And the question is there really a difference in the patient that has a change at minute 10 between minute 11? And I'm saying this to you as clinicians out in the field, because sometimes patients do come back and they've been told, I don't have POTS. But if you actually can look at their tilt table, sometimes they do have, I mean, it's not necessarily that we've done enough studies that we can say, oh, a healthy person might have the 30 beats per minute at 11 minutes. We don't really have that data. So you have to take a holistic view of the findings of a tilt table, and perhaps they don't meet the strict criteria for POTS, but I can tell you my patients that have something like that where at 11 minutes they meet criteria, they respond to the same treatments, they respond to the same therapies. So it's important to take the whole picture, and that's also including the orthostatic hypotension. So whether or not they meet the strict criteria, treatment of the patient is the most important thing. And so here's an actual picture of a tilt table. And just for a point of reference, the syndrome wasn't named till 1993, which is part of why we really have to get the education out there, because, so this was only named in 93 and things don't make it into the textbooks very quickly. And yet this disease is much more common. Mayo Clinic has estimated it at 1 in 100. So it's important to know. And although it's named for the tachycardia, it's not a cardiac condition. The tachycardia is really compensatory, and it's preserving the blood flow in the body because there's likely a neurofailure of the control of the vasomotor innervation of blood vessels. And so to preserve the blood flow, the heart increases the heart rate to maintain stroke volume, right? Or cardiac output, not stroke volume, to maintain the cardiac output. And that sometimes if you can increase stroke volume through conditioning, that's why sometimes that can help alleviate symptoms. So where does it tie in? Some of the theories of how this ties into long COVID is that, so you have the viral insult and then several mechanisms that it may be affecting the circulatory system directly in a way that leads to hypovolemia, also through inflammation, and then neurotropism, which may be interfering with small fibers and affecting the vasomotor innervation. So what happens when you, when these fibers, the vasomotor innervation is affected, you have trouble returning the blood to the brain. And so the body compensates with the fight or flight mechanism. The diagnosis often is made by history and then orthostatic testing, and then cardiology to rule out other sources. You want to make sure the heart is normal. In a regular cardiologist, you don't have to go to a POTS specialist, but if you can at least get cardiology on board to assure that the heart is safe for volume expansion, which is one of the treatments we like to use. And emphasizing why this is so important. Many POTS patients have to drive over 100 miles to see a specialist. I know that most POTS clinics have at least a 2 to 3 year wait list. So it's the more that we can get community diagnosis and at least first line treatment, the better we can help patients. If a tilt test is not available, you can do heart rate and blood pressure in sitting, supine, laying, like so bedside orthostatics at the 10-minute intervals. So you can use this to rule it in, but I would not use it to rule it out. So if you can see the 30 beats per minute increase, then you can use that for diagnosis. But some patients will not show it on a bedside. They need the tilt table because it kind of relaxes the legs. So you can use it to rule in, but not to rule out. And just some of the classes of medication used to treat. So pharmaceuticals, and then here's where this really ties into how workplace accommodations are really going to matter. Okay, so one, people need to take their medication. Sometimes they need to take it with food. Sometimes they need to take it not with food. And also eating can have big effects on symptoms. Sometimes people get better with eating, some get worse. And then exercise. Now I want to caution you, some patients are extremely exercise intolerant, and for them, it's pacing is really important. So because you exercise when people have very bad post-exertional malaise appears to be disease modifying and can make things much worse. But so for those patients who benefit from exercise, having time to exercise, even some short breaks at work in order to do a little bit of exercise that creates cardiac return, or to do counter maneuvers. So counter maneuvers is something like laying down on the ground with your legs up, helps return the blood to the brain, can alleviate POTS symptoms. And then the more you alleviate symptoms, the less you will get the sympathetic overdrive. And so then you have that whole cycle doesn't continue. And then also water and salt. So this is essentially volume expansion therapy, where you're trying to increase the amount of volume in circulation. And that alleviates symptoms, but it can also lead to a large need for bathroom breaks and a lot of need to access fluids. So some workplaces don't want to just allow people that. That's another accommodation that you can actually ask for. And then just to familiarize you really quick with the triad of POTS, Ehlers-Danlos, and mast cell activation syndrome, in case you haven't heard of these. And perhaps it might sound strange if a patient comes in and it sounds like, oh, they have all these rare things. How's that possible? This is really a triad that very often is together. It seems like perhaps Ehlers-Danlos is the underlying genetic component that causes a vulnerability to the other two. And in mast cell activation, you can see patients that are very sensitive to medications. They seem to get side effects from everything. But if you stick with it and keep trying different things, sometimes compounding pharmacies, you can find something that works. And mast cell can also require diet modifications. Yet another place, I just wrote a letter for a student recently asking for a school dietary change to accommodate the mast cell activation. And because her health has improved so much by making dietary changes. So further accommodations for POTS, just a little bit about my specialty and what we do. The core of what occupational and preventative medicine does is we make the workplace safe for workers and make workers safe for the workplace. And we do it doing a variety of things, including pre-employment exams and environmental assessments. So an important concept that we talk about a lot in OEM is the concept of presenteeism, where it's not just whether or not someone shows up to work, which is absenteeism. Presenteeism is about the quality of how someone shows up. And when we make disability accommodations, we're allowing our patients to be present. And so they can really perform their best at work. They're just not showing up and only halfway there because they're ill while they're there, and they're only showing up so they can keep their health insurance. Presenteeism is about allowing people to flourish. So some examples, how do we get presenteeism with a POTS patient? So a long COVID patient presenting with POTS. So for instance, for brain fog, they could show up to work not being, well, so this would be absenteeism, actually. We'd want to fix this so we could have presenteeism. They could show up to work not being able to elevate their legs. So although they're present, the brain fog makes it impossible for them to concentrate. Infusion days. So IVIG or normal saline is a treatment that can be very helpful for dysautonomia patients. So on infusion days, if they're able to work from home while having an infusion, but the work policy is that they have to attend in person. So to meet this schedule, they show up, they delay their infusions, and that causes worsening of symptoms. And say sleep. They have a job with a variety of shifts. One shift interferes with sleep and then worsens symptoms, and they continue to get scheduled and have brain fog and fatigue. My first residency was in psychiatry, and I was able to take a patient off of lamotrigine by just asking their work to stabilize their sleep schedule. That's the power of workplace accommodations. And here I want to emphasize that the note does not have to be anything elaborate. I think often clinicians are intimidated by the language that's needed. It can be very simple. So, find a template or something to help yourself. And I know that this was talked about a lot last week, but number one, do not be intimidated. This is different than giving an expert opinion. This is not as elaborate as an expert opinion. And one of the last things I want to, if you haven't seen this, and I'm guessing you haven't, because I don't know that I've ever tried introducing it and had someone see it who had recognized it. So this is the Job Accommodations Network. This is such a wonderful resource for clinicians and patients alike. And just this is the pathway. So it's called Ask Jan. It's a government website. And then if you go to accommodation search, and you can see all kinds of things. These are just types of things that you could search. You could search aging, back impairment, cancer, air irritants. So you can search by organ system, by treatment. There are so many pathways to get you to where you want to go. And what this does is, first of all, it gives a brief overview of what you've just Googled or what you've searched for. I put in POTS, and then gives you a list, and this also the patient, right? So things they can consider, and sometimes I give this to them and they go, oh, wow, I do these things at home, and I never thought of how to articulate, how to ask for that in a workplace setting. So here's just an example of what you get back if you look for POTS. So for decreased stamina, allowing breaks, flexible scheduling, working from home, ergonomics. Other symptoms, dizziness, providing chairs, providing stools, allowing rest breaks, or modifying tasks. Gross motor, again, ergonomic considerations, which I also encourage you to, if you want to learn more or have a quick ergonomic tool, it's called the REBA, which is, if you just Google it and look it up, it is totally self-explanatory if you want to do an ergonomic assessment for yourself, for your patients. REBA. And then effective medical care, again, allowing work from home, flexible schedule, and time to recover after treatments, and safety standards, having safety plans, and then purchasing protective equipment such as fall protections, edge cushions, alerting devices, or machine guards. And that brings me to the end. I thank you for your attention, and I'm looking forward to the panel.
Great. Thank you so much, Sarah. That was a great refresher on POTS. It's been quite a while since we've talked about it. And then I love how you used it as kind of a prototype or a framework for occupational medicine. And we've got a lot of questions coming in already. So I want to introduce our panel and then throw it to John for our first question. But you probably know our next panelist quite well, Alba Azola. She's the director of the Physical Medicine and Rehab Post-Acute COVID Team Program at Johns Hopkins, and she's an assistant professor of physical medicine and rehab there. And then we're delighted to have Alice Perlowski as our panelist as well. She's the chief medical officer and founding director of Blooming Magnolia and is a cardiologist and patient lived experience expert joining us. And we already introduced Sarah. So John, let's get started with the questions.
Yeah, I think we're going to go to Alice for their first question. So Alice, you've shared that you've battled long COVID in prior sessions. Just wondering if you could share kind of the experiences and challenges that you've had to go through and how you've adapted to them.
Sure, thank you so much. So yes, I had a pretty bad case of initial COVID and long COVID that affected almost every body system. It's not lost on me that I'm a cardiology and vascular specialist, and now I have a vascular condition. I'd say occupation-wise, the most debilitating symptoms I had were initial cognitive impairment. So loss of executive function, multitasking, which was something I did all the time. The postural orthostatic tachycardia syndrome was a significant problem because I was used to standing for 12 hours a day doing procedures and things like that, which became impossible. So the way I adapted my work was I had to start working from home, which enabled me to assume a sitting position most of the time, be able to hydrate and take biologic breaks, as one of the chairs said before. I love that term, as needed. That's not something I would have been able to do in my previous positions. Also, I took positions where I could work a certain number of hours per week, but as needed when I was feeling up to it. Which is different than a shift work where I'd have to show up at a certain time of day. So that's worked well. And I also have, and I know that this isn't possible for all patients, but I let the people I work with know what was going on with me. And I think that helped the understanding of the condition for my fellow colleagues, but also to give, some sort of understanding as to my schedule needs. I hope that helps.
Thank you.
Great. I want to bring Alba into the discussion. And Alba, so I know you are not an occupational medicine specialist, but of course in your work, you confront patients like this a lot. And I think we're getting some questions about what the role is of the primary care provider here. What do we do in terms of this whole arena of getting patients what they need in terms of work accommodations? It's not something that we as physicians are generally all that comfortable with outside of occupational medicine. What has been your experience, Alba?
Yeah, thank you so much for having me. And as a physical medicine and rehab doc, we certainly deal with a lot of disability. Our population has disabilities, so we're kind of trained not as not as detailed as the occupational doctors, but we do have some knowledge and understanding of function and how that can be modified at work so that we can get the patients back to their lives and doing things in a different way. So I think that primary care physicians have the knowledge to do this. I think that What we need is not a specific test or a set of complex workup. What we need is good documentation regarding the patient's function, regarding what are the things that they were able to do before that they're not able to do now, and really go into detail about those limitations. That documentation is really helpful when you're trying to support accommodations or when you're trying to support disability and things like that.
Thanks, Alba. I think the next question will probably be best for Sarah, and it's a question from Vindra. And they write, in many cases, employers can do just above nothing to say they provide accommodation. So who determines if the accommodation provided is adequate and effective? Kind of like, what's the follow-up on that? Great question.
Right. So, I mean, the lawyer has a duty to engage in the reasonable process, or good faith discussion, but sometimes that's just not working. So the least financially burdensome next step, if is to go to the EEOC. So to file a complaint with the Equal Employment Commission. Sorry, I forget what they all stand for right now. But and then you can also hire a private attorney, which is cost prohibitive. And I mean, I understand this whole process escalates things. So it really depends on where a person is, how close they are to not being able to work. Sometimes this is it. If they don't get the accommodation, there's not going to be a job in a month. So they essentially have no choice but to escalate things.
All right, next question is really geared towards diagnosis of POTS. So thanks for the review, Sarah. And this one is really for any of you. We have a cardiologist, and then Alba, I think, already answered this question in the chat. But for diagnosing POTS in the office, not everybody's going to have a tilt table available. Actually, I think very few people will. So what do you use in terms of diagnosing in the office? Alice, can you give advice, and then Alba maybe jump in?
Well, I'm not actually seeing patients in the office right now, so I can give you, something kind of creative I do when the person's at home, and I essentially do a NASA lean test with them. A lot of the people have wearables, so we can sometimes make the diagnosis of POTS even with the patient at home via telemedicine. I'm sure that Alba has something to add for patients in the office.
Yeah, not much. I actually just posted the link to the Bateman NASA lean test PDF, which is really useful. I use that for patients in clinic and at home to track symptoms, respond to medications. It's a really useful tool. I think that clinicians that have the chance to have the patients in person can gain so much from actually doing the 10-minute stand test, not only looking at the response of heart rate and blood pressure, but looking at symptoms. You can see increase in their breathing rate. You can see their palms or their feet start mottling and turning darker. You can see the sweating. I mean, it really, for me as a patient, as a rehab doc that just stumbled into the world of autonomic dysfunction and fatiguing illnesses, it was very much of a shock to be able to see those findings and to really understand, what the patients are experiencing. So anyway, those are my 2 cents on that.
Great. This one's for everyone or anyone who wants to take it. And it's from Renee. She asks about the role of community health workers. Can they educate patients or employers about the need for accommodations? Just wondering if you can extend their role into the workplace. So I don't know who wants to take that one. Sarah?
Yeah, I think community health workers have a lot. I think first, we need to educate each other. I would encourage you to educate your colleagues first, because if you know about this, you're probably unique. And that's something that I continue to rediscover with every room that I go into, is like, wow, we really need to incorporate this into some more of our curriculums. but also educating your patients, and then moving out from their leadership roles. But it starts at home with your colleagues and your patients, and encourage. I always say, like, take this knowledge and tell it to someone else too. So I try to spread the seed.
Thanks for that. I want to combine two questions, both from Deborah Donnell, and I'll direct this at Alice Perlowski. So the questions are about, is weight gain in and of itself associated with POTS? And I think I saw somebody answer already in the Q&A, but then also the question gets to physical activity. And this seems to be one of the things that we struggle with the most, is how do you advise people about physical activity when they may have POTS or post-exertional malaise?
Yeah, so first, weight gain is pretty common when we see POTS. We see a lot of fluid shifts and fluid retention in these patients. Also, screening cortisol is also a good idea. I'm sure your doc already did that. But in terms of returning to exercise, what I did and what I advise patients is to start with the recumbent type exercises, if that's possible for you. So things like swimming, recumbent bikes. Sometimes when you're trying to exercise, when you're in an upright position, it exacerbates all the symptoms. So, I would advise try those first, and try not to. I get a lot of questions about people, what should the heart rate be? And my heart rate's really high, and then people get very panicked. Try not to look at the heart rate that much. Just try to go with your perceived exertion and your symptoms. I always advise people try not to push through cardiovascular symptoms like chest pain. If you're having that, back off. And then, it's a nonlinear recovery, and it's not the same for all. So it really varies based on the patient and how you're doing.
I think
Great.
one thing that's important too and challenging is keeping eyes open to see if there's also a diagnosis of myalgic encephalomyelitis, formerly known as chronic fatigue syndrome. And we do see a lot of overlap. And where at one time the prevailing thought was exercise is great for ME, it actually seems to be really problematic and can be disease modifying in a negative way. And I mean, I continue to learn about this every day and try to suss out. It's really hard because some patients, exercise is so great and it's the path to recovery, and others it makes them sicker. But it seems like the post-exertional malaise, if they're feeling terrible 1 or 2 days later, that is a warning sign. That is something to be paid attention to and to consider moving into pacing.
Thanks, Sarah. I've got a couple of follow-ups actually. So this actually came from Denise King related to ME/CFS. And the question is, have you encountered post-COVID patients that now have ME/CFS? I think you answered that. We understand this is sort of a subset of long COVID. But further, her question is, what degree of disability do the patients with ME/CFS have?
So I can take it.
Go ahead, Alba. Yeah.
So it depends, like ME/CFS is a spectrum, right? We have different levels of severity, from mild to very severe, which is homebound, bedbound, unable to get up, to somebody who experiences post-exertional malaise after going for a jog. So there's a large spectrum in terms of the clinical presentation. So I would say it's very individualized. I think that this is what I tell my patients. Usually when they're experiencing post-exertional malaise, they get on the Corona coaster, which is kind of the feel good, do a lot at work, and then crash hard and have to be calling out sick because they can't get out of bed. When I see that trend, I see an overall decline in function and ability to sustain activity. So that's an important piece. It's important to make accommodations to prevent the frequency and intensity of crashes. Crashes happen, but we need to work really hard on staying within the envelope and preventing getting into that crash cycle. I think I've seen function improve with that. I think at work it's really important to think about not only the activity that you're doing physically, but environments that are hyper-stimulating, environments that are requiring commuting, driving. Driving is a skill that seems pretty straightforward, but it requires a lot of cognitive input. So you can do accommodations for remote working, for being able to have flexible hours. Sometimes they can do work in the computer in the morning and then the brain fog hits hard, or they need to have breaks of 20 minutes in between work. So there's a lot to that, but it's very individualized, and depending on the patients. I certainly see patients in the whole spectrum. So we work on accommodations for both, for all.
Thanks for that, Alba. And then Alex Waters had one specific question. We have a very sophisticated audience here. So yes, we know about pacing, and of course you want to prevent the post-exertional malaise if you can, but what about during an actual episode? And maybe I'll turn to Alice. If you've had a crash or a post-exertional malaise episode, what can you do in that moment? You're on mute, Alice.
Sorry. Yes, in that moment, rest, back off. This is not the kind of illness that I've seen people have before where they could potentially push through a crash. It's best to immediately back off. I also, in addition to the exertional and cognitive exertion, I also asked people to log what they had been doing or the circumstances in the week prior to the crash. So some people have mast cell activation issues, and so some certain foods can be triggers for the crash in combination with the exercise. So I think what has helped me personally too is to log every single thing I've done to recognize what is contributing to the crashes, so that maybe you can prevent more in the future.
Great, thanks.
So I wanted to ask a question to either Alba or Alice. It's about blood flow restriction training. Just wondering if you guys have any experience using that as a treatment for the post-COVID related exercise intolerance. I'm not as familiar with that, so maybe you can educate us on that. No?
I have to be transparent. I'm not familiar, at least by that name.
Okay.
I'm sorry, I'm not either.
Well, that makes three of us. Yeah, Althea, if you want to put in the chat stuff that you learned, that we're all learning. So
I'm only mildly, I wrote a little bit about it in the chat because I've seen it done by physical therapists. So it's actually where it's almost like a blood pressure cuff. And say you're having leg pain, specific types, and they actually use the cuff to restrict the blood flow for a certain amount of time, and then you perform exercise and you actually get a higher yield on so it kind of changes the biochemical environment. And so just a few minutes of exercise will be like you exercise for an hour. And I had asked about that at one of our noon conferences. I think someone said it was either no, like they had tried to no avail, but there just didn't seem much of an appetite to. I still remain curious though.
Thanks, Sarah.
Sometimes things seem counterintuitive. Like for years, we didn't use beta blockers in heart failure because it seemed counterintuitive, and now we know they're really important. So I'm still curious.
Thanks, Sarah.
Speaking of beta blockers, actually, there was a question that came up earlier about a patient who's on 40 milligrams of propranolol a day. That seems like it's for anxiety or maybe performance anxiety indication, but that patient feels like her symptoms are worse without the medications. Also feels like she needs a higher dose. Now, and I'll give this to Sarah or Alice. Is this something primary care folks should be trying out if they think somebody does have POTS, and maybe a first trial of a beta blocker to see if it helps? Alice, start with you.
Yeah, sure. I mean, I think beta blockers are a very safe medication that a primary care physician can start initially for POTS. On the specific question, of the propranolol for anxiety, I'd really want to know, is this long-acting propranolol or is this short-acting that's being given one time a day? Because the issue with beta blockers is you have to really look at half-lives and when it's going to wear off. I've seen in some cases with short-acting propranolol given once a day, there's a rebound effect, so people get more anxiety. And I'm not sure what's going on in this particular patient, but mind the half-lives of the beta blockers and dose accordingly.
Great. There's a question from Deborah about the overlap between PANS and PANDAS. And I think Deborah is a behavioral pediatrician, and just wondering if you could elucidate a little bit more what that is, if you know, and kind of how this could be delineated from post-COVID conditions.
I can take it. So there definitely is an association. I mean, we've seen patients with PANS and PANDAS. It's not entirely clear, again, with this kind of being a spectrum, right? Like in many ways, we don't know what actually causes the POTS or dysautonomia, but we know what helps it. So the way I was trained was largely from a treatment functional approach. And, also I have a research curiosity. But like we have patients who are in front of us and these treatments, so I wouldn't approach it too much differently in a patient that had co-occurring PANS, PANDAS, and unless there was I would just look for side effects that I was worried about for like first line POTS treatments, making sure that there was nothing I was worried about with the other medical conditions.
Thanks, Sarah. And just for those of us who are not familiar with that abbreviation, can you remind us what that stands for, the PANS and PANDA?
Yeah, so it's, I would have to look up the whole thing, but it's a post-streptococcal syndrome of brain syndrome that occurs post-strep.
Thank you.
Put her on the spot there, John. It's I have Google to help me
Been a
out.
while since I've been in psych, but yeah.
Pediatric autoimmune neuropsychiatric disorder associated with group A strep. So yeah, one of those oddball diagnoses. I have a question that actually it looks like Alba wanted to answer live, so I'm happy to give it to you. This is from Juan Benzo about the role of physical therapy for POTS. He says, I was trained as a physical therapist and we were trained on testing and treatment for POTS. Have you researched the efficacy of physical therapy for POTS? And do you think PCPs should refer people right away to physical therapy?
Yeah, so this is actually that we have live experience with. In our institution, we have a POTS clinic. So initially, when I started seeing these patients with POTS-like symptoms, I, kind of gathered the therapists that treat POTS patients, and I started sending the patients there. Some patients that have POTS can really benefit from physical therapy. It increases the total blood volume. There's many benefits to physical activity, physical therapy. And there's various protocols that can be followed, but not everybody with long COVID can be referred to physical therapy. It is extremely important to screen for post-exertional symptom exacerbation. And this is kind of a tricky thing to identify, but not really. But we don't usually ask about it, right? Because we hear fatigue and that's it. But it's really important not to send patients to physical therapy that are experienced post-exertional symptom exacerbation. And if you do refer them to physical therapy, there needs to be a therapist that's very familiar with long COVID and that understands. Because so our therapists in our institution started seeing these patients and they were not able to treat them. They were crashing and getting worse. So we really learned the hard way by seeing patients getting hurt. So it's really important that you send it to the correct physical therapist and that you screen for PEM or PSA. Yeah.
Just an illustrative example of this. I have a patient, extremely motivated patient, always wants to do more. She has ME. And even just doing Tai Chi has sent her into weeks-long crashes. And I think we tend to think of exercise as, can you get through the exercise? She can get through the exercise. It's what happens the next day. That's where it's at. And so really, I mean, that is post-exertional malaise, doing a little Tai Chi in the chair, and you can't get out of bed for weeks.
Great, thanks. And just a clarification in the chat about the last question, PANS. It can be from any infection, not just streptococcal. So appreciate people following up on that. I got another question from Vindra about patients who have really low heart rates, like around 50. They're often told that they're athletic, but he just wanted to point out that sometimes POTS and dysautonomia can present with a low heart rate. So I'm just wondering what kind of education awareness there is for low heart rate in these non-athletic patients. Maybe Alice, you want to answer that? Although I see you shaking your head too. So start with Alice.
Yeah, I mean, I get consulted all the time for, for low heart rates. And I think that we have to recognize that if somebody is not an elite athlete and they're having heart rates in the 50s, varying up to the 120s, that's not a proper heart rate variability for an elite athlete. So it really, you have to take the entire clinical situation. Of course, I've had patients who are in even the 40s who are complete elite cyclists and things like that. But if you have somebody coming to you who has that kind of heart rate, it deserves investigation unless somebody is really truly an elite athlete. And I agree with the person who said that more education needs to be given about about autonomic dysfunction in general. I just don't think, even cardiologists, a lot of them don't understand it.
Yeah, I just want to piggyback on that, that with dysautonomia, it doesn't mean that it's always going to be an elevated heart rate. I have seen patients with a flare where activity induces episodes of bradycardia and they become symptomatic. There's actually papers out on sick sinus syndrome after with dysautonomia that can be developed. So I usually just I'm actually going to ask you the question. I usually repeat a CO patch and then send them to cardiology to make sure that everything is good. Yeah.
Yeah, I think that's fair because one of the parts of dysautonomia is a sick sinus syndrome or SA node issues. So I think it's fair. I would never deny a consult like that.
Great. Well, unfortunately, we're at the end of the hour. I'm just going to start to bring us to a close here. What a fantastic panel. We're getting some praise in the chat already. So thank you so much. Great talk, Sarah. Thank you, Alice, for sharing your own lived experience. And then Alba, thank you as well for sharing your perspective. I wanted to let everybody know, first of all, thank you so much for all of those that have shared resources. Again, one of the things that we like to think that we're doing here with this national webinar is really collectively sharing resources. So all of you that shared links in the chat, of course, we will compile those. And I know we didn't get to all of your questions, but we also have committed to answering them. So our panelists are going to help us wrap up answers to all those that we didn't get to. And then we will post that on our website as well. You can just search LC and FERP for long COVID and fatigue illness recovery program. That'll bring you right to the University of New Mexico website where all the recordings are, as well as all the resources. I wanted to mention that the third quarterly short course, which is for those who can't make the live sessions or want additional supplementary education asynchronously, is available, but it's going to close very soon on December 12th. So that's only open for another couple of days. Jane is going to share the link in the chat. There it is. Okay. And then, of course, we're going to reiterate again in the new year with another short course and maybe take a slightly different approach and make it more thematic rather than just sort of the last couple of sessions that we've had. I also wanted to let everybody know about our next session, which is going to be next year, January 12th, my birthday. But unfortunately, I won't be here for the session. Bruce and John will be facilitating that one. And what we decided to do for this next session is really go back to basics. We're a year in to this program, and there's been some new understanding of long COVID and post-COVID conditions. So we're going to re-ask some very fundamental questions about what is the true incidence of long COVID? Has it changed over time with various waves of infection? Does it matter if it's your second or your third COVID infection, and what does that impact have on the incidence? We'll talk about what we know now about the natural history of long COVID. Do people get better? And sort of comb the literature for that. And then we'll just sort of give a nice forward-looking view of treatments and what's being looked at right now. Obviously, the evidence is just slowly stacking up, and there's a lot from the RECOVER program from the NIH that really has a long way to go before that's going to be published. But Dr. Jason Maley and John Barata from Harvard and UNC, respectively, are going to help us work through all of those topics with help from Cindy Bateman and Hector Bonilla as well. I think that's all I had. And thank you so much for attending. And again, thanks again to our panelists for a great session. And stay safe, everybody, and have a happy holiday.